take the retracted tendon to the lateral part of foot bridge. Why? The ARADER is similar, but what causes these differences? So preoperative recoverability is very important. It's the first step to avoid the repair. So there are many accessibility tools using. It was a revision potato cup mixed with basic things. So when we see the systematic review, it was published, a paper published in 2014. They analyzed 8,000 shoulders, and the study period, they collected the papers from 1980 to 2012. The return rate was 26. So based on this one, if we see the real numbers, in the USA, they do the potato cup repair 600,000 a year, 20,000 repairs. Surgery we've done in a year. It's a lot. So patient factors, these are the known patient factors, but not strictly, because only one paper just said, okay, age is related, I included, and then various underlying disease. I also analyzed my patient factors, systematic review, multi-arm analysis. They said that these are the traditional factors: hair size, fatty infiltration, and then muscle atrophy. These three things are strongly supported from many studies. But these things, retraction and then osteoporosis, is supportive from few studies. And then rest of things is a conflicting evidences. So I don't agree this osteoporosis related with the bone and the tendon healing. Anyway, few studies supported this one. And then these are the traditional studies show that are related with it. Some I agree, some are not. So when I see my patients, also initial size, take the retracted tendon to the lateral part of foot bridge. Why? The ARTHROSCOPY is similar, but what causes these differences? So preoperative recoverability is very important. It's the first step to avoid the repair. So there are many accessibility tools using